Alright, good evening. I am Basant Mohamed and this is my colleague.
I'm Hajjaj.
So we'll be talking about the ventricular system and scalp and dura.
And the physiology of the CSF.
Alright, so the ventricular system is basically connected cavities in the brain. It contains cerebrospinal fluid. This is how it looks. So it's made up of two lateral ventricles, a third ventricle and a fourth ventricle. We have a lateral ventricle in each hemisphere, and then, oh, I can draw, alright, good. So here, this is the interventricular foramen of Monroe, which connects between the lateral ventricles to the third ventricle. And then from third ventricle to the fourth, we have the cerebral aqueduct of Sylvius, or just cerebral aqueduct. And then from the fourth ventricle, we have three apertures to where it connects to the subarachnoid space. Subarachnoid space is the space all around the brain and the meninges, the dura, arachnoid, and pia. It helps cushion the brain, protect it from any physical trauma. So we have three apertures, two lateral apertures of Luschka and one median aperture of Magendar. Oh, I want to mention, very important to know that the cerebral aqueduct, which connects between the third and fourth ventricle, is it's like the narrowest part of the whole ventricular system. So it's the one it's the most common site of obstruction. Here, this one, you can see it's very thin, and it would cause non-communicating hydrocephalus since it's an obstruction occurring. I will explain that in a bit. Alright, so what's the origin of the ventricular system? Basically, it originates just like the rest of the brain from the neural tube, specifically the lining of the neural tube. Next, please. So basically, the neural tube is going to give these embryonic brain regions. We have the forebrain, midbrain, and hindbrain. The forebrain separates into telencephalon, diencephalon, and then telencephalon is going to give the lateral ventricle, diencephalon is going to give the third ventricle, and the thalamus. I will get that. I'll get about this point in a bit, but it's very important. The midbrain will form the cerebral aqueduct, hindbrain the fourth ventricle. So we have something known as cisterns. Basically, there are four cisterns, at least the ones we need to know. And these are areas where the cerebrospinal fluid collection is just wider. So usually it's in the ventricles, but with these cisterns, like this one, this is the superior cistern. It's present above the cerebellum and behind the midbrain. Here we have the cerebellomedullary cistern. It's the biggest one, also known as cisterna magna. And then we have the interpeduncular cistern. It's known as interpeduncular because it's present between the peduncles of the midbrain. And then we have the pontine cistern exactly in front of the pons. Okay. Again, next please. So this is what I think you should know about each cistern, other than its location, of course. The quadrigeminal cistern contains the great vein of Galen. The great vein of Galen, why is it kind of relevant? It drains a lot of important structures in the brain, like the thalamus. The cisterna magna is the biggest one. And the interpeduncular, which, as I said, was in front, peduncles of the midbrain, contains the circle of Willis. Circle of Willis, maybe didn't take the lecture yet, but basically it contains the anastomosis of some of the important the arteries for the brain that supply the brain, like the anterior cerebral artery, the posterior cerebral artery, the anastomose in the circle of Willis. Then we have the pontine cistern. It contains the basilar artery. The basilar artery is the blood supply of the bones. How do I erase these? I'm gonna erase them for the questions. Okay. Can anyone read the question? We'll solve it together.
يلا
Okay.
6-month-old infant has progressive head enlargement. MRI shows dilation of lateral and third ventricles, but normal fourth ventricle size. Which region best explains the pattern?
So basically, what's dilated? The lateral and the third ventricle, but the fourth ventricle is normal. So let's imagine there's something. So if these are the lateral ventricles, the third ventricle, the fourth ventricle, we have a lesion here. What connects the third ventricle to the fourth ventricle? Yes, exactly. So the answer is A. I really need to erase these.
Try doing this.
At the left there is a sidebar, I think.
Oh,
okay.
Yeah.
Oh, it works, but it's not that. a side pore.
On the side, there is no options. No, yeah.
That's just familiar.
All right, I'll stop drawing. Anyways, this is a normal MRI of the brain, magnetic resonance imaging, and we have two types. We have the T1 and the T2. What's the difference? Basically, in T1, any fluid, the cerebrospinal fluid, is gonna look black, while in T2, it's gonna look white. They are used for different reasons, but what we really need to know is that the way I imagined, the way I memorized it is that T1, the one looks like an L, and black has an L. So in T1, the fluid will always look black. You see, these are these are the lateral ventricles. Here we have the anterior horn, the posterior horn. So the cerebrospinal fluid inside looks black, while here it looks white. So if the fluid looks white, this is T2. If the fluid looks black, this is T1. All right. For the anterior horns, as I mentioned, the lateral ventricles, they have anterior horns, posterior horns, and inferior horns. In this image, we can't really appreciate the inferior horns, but we can see the anterior and posterior. What you need to know, and it's a really high yield to know, the anterior horns are medially, they are surrounded by the septum pellucidum here. This structure is the septum pellucidum, and laterally by the caudate nucleus in these two areas. And then the inferior horn is related to a structure known as the hippocampus. The hippocampus is related to memory. You just need to keep that in mind. So let's imagine hydrocephalus occurred, and the inferior horns of the lateral ventricles were affected. What will happen is that it can compress the hippocampus, and the patient will come with some sort of memory impairment.
What's the septum pellucidum again?
The septum pellucidum is, you didn't take it yet, you will have a lecture about it later, but it's basically white matter. It has...
Not the thing in the middle? Here.
Here's
Yeah.
Oh, it's within
Yeah.
that, okay.
Alright. This is another MRI. As you can see, here is the lateral ventricle, corpus callosum. Oh, okay, yeah. Can you go please to the... Basically, this is the septum pellucidum. It's surrounded by the corpus callosum laterally. This is the septum... What's this? I'm not sure. Okay, but basically the corpus callosum on top, septum pellucidum in the middle. So laterally, it's surrounded by the caudate nucleus, and medially by the corpus callosum. Septum pellucidum is the one in the middle. How do I remove this? Okay. As I said, lateral ventricle, body of the corpus callosum. You can see the pontine cistern here, fourth ventricle, the quadrine cistern. Cisterna magna is also visible. All right, let's talk about hydrocephalus, but in details now. Hydrocephalus is basically accumulation of the cerebrospinal fluid in the ventricles. It will lead to ventricular dilation, and will also lead to increased intracranial pressure. Not in all types. We have 4 types that we're going to go through now. The symptoms are, so what happens is when hydrocephalus occurs, we will have ventricular dilation, which causes increased intracranial pressure. This increased intracranial pressure will lead to headache, nausea, vomiting, papilledema, and some sort of cognitive changes. So these are the signs. Alright, types of hydrocephalus. We'll start with communicating hydrocephalus. From its name, communicating, so there's no blockage. So cerebrospinal fluid will be able to flow through the ventricles, then to the subarachnoid space. There's no blockage, but why there's some sort of obstruction? Because the arachnoid granuli, the arachnoid villi are scarred, or they're not functioning properly, so they're not absorbing the cerebrospinal fluid as they should. So what will happen is cerebrospinal fluid is going to accumulate all over the ventricular system. A key point here is that it will be dilated symmetrically. So it will be dilated in the lateral ventricles, and third ventricle, and the fourth one, all over. What are the causes? Usually meningitis. Meningitis will cause a sort of like scarring and adhesion to the arachnoid villi. Also subarachnoid hemorrhage, the blood will make the arachnoid villi function harder. And then we have post-surgical or post-traumatic surgeries. Okay. Here's an MRI. This is a CT scan. So to differentiate between an MRI and a CT scan, in a CT scan, the bones are always really like bright white in color, So as you can see, this is the skull, and it's bright white. This is a CT scan. Well, this is an MRI. Can you tell me this is a T1 or T2 MRI?
T2.
Yes, exactly. It's a T2. As we can see here, the lateral ventricles are enlarged, the ventricle is enlarged, all of them are enlarged basically. And same thing here. This is the lateral ventricle, anterior horns, posterior horns. Can't really appreciate the inferior horn here. But since it is communicating, all of them are dilated symmetrically because there is no obstruction. Now, non-communicating obstructive hydrocephalus. Here, this is when there's a blockage within the ventricular system, and what will be enlarged is based on where the blockage is. So CSF won't be able to reach the subarachnoid space, and when some part of the ventricular system will be dilated. Causes. Most important cause is aqueductal stenosis or aqueductive sylvius that connects between the third and the fourth. It will get stenosed, and you need to know two reasons for this stenosis. Sometimes it can be congenital. So the most basic question that you can see is a child that was just born, newborn, and he has hydrocephalus. Most of the times the cause is aqueductal stenosis, congenital aqueductal stenosis. He was just born with it. We can also have, this question is very high yield. We saw it before. Anterior thalamic tumor. So basically the interventricular foramen of Monroe, if it becomes obstructed, I said it was like, it was surrounded by the third ventricle, right? The third ventricle is surrounded by thalamus. So the interventricular foramen, which drains from the lateral to the third ventricle, would get obstructed, causing non-communicating hydrocephalus. Also, Chiari malformation, I'll get about it in a minute. Congenital anomalies. As I said, ventricular enlargement will depend on the site of obstruction, and most common congenital cause is aqueductal stenosis, but it can also occur in old age. So it has two reasons, either congenital or in old people. Okay. Now let's see an MRI for non-communicating obstructive. This is an MRI. As you can see, the lateral ventricles are widely dilated. But here, let's focus on this picture. So the lateral ventricles are dilated, already saw that there. And here, the third ventricle is also dilated, but the fourth one looks normal. So where do you think the obstruction is? Yeah, exactly. Now, normal pressure hydrocephalus. So I did mention before that when hydrocephalus occurs, the intracranial pressure increases, but not here. This is the third type. So normal pressure hydrocephalus is when ventricles are enlarged, but the cerebrospinal fluid pressure is usually normal. But why does hydrocephalus occur? Due to impaired absorption. So there's this mnemonic where each patient with normal pressure hydrocephalus will present with wet, wobbly, and wacky. So they will have urinary incontinence. They will have wobbly as in gait disturbances. They will have like a wide-based gait. And this is the earliest sign, by the way. So like if the doctor can notice this sign early, they will be able to reverse the dementia, because wacky dementia occurs, and it's reversible if it was treated early. Cause for normal pressure, honestly, it's idiopathic in elderlies, or it could be secondary due to trauma.
It's like communicating hydrocephalus, right? Because the
yes, because it's
the absorption.
Yes, because it's a problem with the absorption, right?
But the CSF pressure is normal?
Yes. Yes. Here, this is a normal pressure lateral ventricle. This is normal, okay. As you can see, everything's fine in this brain. This is a T2 MRI. But here, as you can see, the lateral ventricles are widely enlarged. But the CSF, the intracranial pressure is going to be normal. And you will see the three signs will be mentioned in the questions. We're going to solve some questions in a bit, but you will always see these three signs. Then we have hydrocephalus ex vacuo. This is how it's called. Basically, it's not really hydrocephalus. It looks like the ventricles are enlarged, but they're not. It's just because there's brain atrophy. So when the brain atrophies, the ventricles will look larger, but it's basically the brain is just shrunk. Causes Alzheimer's, Huntington's, and age-related atrophy. ICP will also be normal. Intracranial pressure will be normal, just like normal pressure hydrocephalus. It's just compensatory dilation because the brain got smaller. I'll show you an MRI now. Okay, normal pressure hydrocephalus. You see this picture? So like here, the brain kind of looks normal to some point, but on this side, as you can see, the sulci are really widened. The fissures, this is way wider than this one, this is way wider, they're all widened. This is hydrocephalus ex vacuo. It's just brain atrophy due to age and stuff. They look larger, but it's not really the ventricles, it's just the brain shrunk. And last point, we talked a lot about increased intracranial pressure. Let's talk about decreased intracranial pressure. So it's basically when there is intracranial hypotension because or dehydration, cerebrospinal fluid leakage. Why would leakage occur? Post a lumbar puncture, post a craniotomy, any skull base fracture. Like actually there was a case where the patient had a skull fracture and CSF was draining from his nose. And they didn't know till they checked. Rupture of arachnoid cyst, age-related atrophy, and subdural hematoma. What would be the signs? Orthostatic headache. So it's worse when standing and just better when lying down. Oh, question. Do you know the site for a lumbar puncture?
Yeah, L4.
Yes, L3 to L4. Okay, these are some causes I would think they're high yield and you really need to know. As I said, the aqueductal stenosis, most common cause of congenital hydrocephalus for the newborns. We have the Chiari malformation when the cerebellar tonsils become herniated. It will block the fourth ventricle. When it blocks the fourth ventricle, we have obstructive non-communicating hydrocephalus. Then we have the Dandy-Walker malformation, atresia of the foramen magendi and Luschka. And finally, hemorrhage, as I said, subarachnoid, interventricular, will cause also. Okay, then finally, infections and meningitis. I'll get in a bit about meningitis. It does a lot of things that we need to know. Yeah, next please. Okay, why is intracranial pressure increased in meningitis? Basically, the inflammation of the meninges would cause, because we said the subarachnoid space is between the meninges, it's between the arachnoid and pia. So when they are swollen in meningitis, it will lead to blockage of CSF circulation, and especially at the subarachnoid space. Also, it will play with the arachnoid villi function, it's affected. Yeah. Then let's talk about physiology of the cerebrospinal fluid. Any questions before I proceed? First, let's talk about the blood-brain barrier and the cerebrospinal fluid, blood-cerebrospinal fluid barrier. So, basically, we have this thing known as the blood-brain barrier, where the brain protects its environment and keeps homeostasis. Not anything in the blood can enter the brain. So, it's present in the cerebral capillaries, while the blood-cerebrospinal fluid. So, basically, you have the choroid plexus, which produce cerebrospinal fluid. They will have their own barrier because cerebrospinal fluid is produced from plasma in the blood, but we can't allow anything in the plasma to get into the cerebrospinal fluid. So we have this blood-cerebrospinal fluid barrier. The main type of cells present in the blood-brain barrier are endothelial cells. They form tight junctions, really tight junctions. And the blood-cerebrospinal fluid, we have ependymal. They are a type of epithelial cells, but all right. So, main type of cells in the blood-cerebrospinal fluid barrier are the ependymal cells present in the choroid plexus. Then the capillaries in the blood-brain barrier, they are non-fenestrated. They will not let anything pass in. While blood and cerebrospinal fluid barrier, they are fenestrated. I will tell you now about the composition of the cerebrospinal fluid in a bit. Then again, endothelial tight junctions and astrocytes. Astrocytes are supportive neuroglial cells. And then choroid plexus, they have epithelial tight junctions. Blood cerebrospinal fluid is mainly to regulate the cerebrospinal fluid composition and production, while for the blood-brain barrier, as I said, is just mainly for protection of the brain's interstitial fluid. All right, for the production, every day, daily, there is 500 milliliters of CSF produced, but the volume in the ventricular system, all of it is just 150. And only 25 are in the ventricles, the rest of it are in the subarachnoid space. And what happens is that the rest of it just gets absorbed by the arachnoid villi. The mechanism is active secretion of sodium, chloride, and bicarbonate, and water will follow, but not all of these particles stay. Let's talk about the composition. Okay, let's talk about the functions first. Functions, as I said, mechanical protection, cushions the brain, buoyancy reduces the brain's weight because we know it's kind of heavy, and then maintains stable extracellular environment, pathway for waste removal, circulates hormones in your blood. Okay, cerebrospinal fluid composition. This is really high yield to know. Okay. Basically, we're gonna have, so as I said, CSF is produced from blood plasma, but how is it different from blood plasma? In cerebrospinal fluid, the protein is way lower. In plasma, it's high. In the glucose, I'm gonna talk about this point in a bit, but basically, the glucose amount in CSF differs when the patient is normal and if the patient ever gets meningitis. So meningitis would lead to decreased glucose amount, and I'll tell you in a bit why. Then we have sodium, it will be slightly increased. Just keep in mind it's increased, okay? Again, high yield. Plasma, whatever amount it is, chloride also increased. Potassium and calcium, they're fine, decreased, and lymphocytes obviously are less. So to summarize, basically CSF compared to plasma will have more sodium, more chloride, and glucose should be 2/3 of the amount present in plasma. So if it's 70 to 110, 2/3 of that. Do the math. Okay. Next, please. So lower protein, lower potassium, lower calcium, but higher chloride and sodium than plasma. Glucose, as I said, 2/3 of the normal glucose present in the plasma, but for meningitis, it will be different. The glucose will be lower. Basically, the bacteria, so in bacterial meningitis, because there are multiple times, in bacterial meningitis, glucose will be decreased because the bacteria is using it up. Yeah. And then higher protein, higher neutrophils. Again, rate of production and absorption is constant. It's not really pressure dependent.
Okay, can someone read this question, please?
CSF is sampled and shows glucose is 30 milligrams, protein is 800, neutrophil predominance. Which mechanism best explains the low CSF glucose?
What do you think it is?
A.
Yes, increased glycolysis by infiltrating neutrophils and bacteria. Because we have bacterial meningitis here. Yeah, so this is just the explanation. Higher neutrophils, higher protein, low CSF glucose, bacterial meningitis. Now CSF absorption, I mentioned that earlier, through the arachnoid granulations into the superior sagittal sinus. So from arachnoid granulations, superior sagittal sinus, it's one of the dural, my colleague is gonna talk about it more. Dural venous sinuses. The absorption is driven by pressure due to the pressure gradient. So the CSF pressure is higher than the normal venous pressure. So that will help that the CSF will be absorbed into the superior sagittal sinus and dural sinuses. And there is some slight additional absorption through lymphatics. Alright, I'll read this one. Which of the following best explains why CSF protein is much lower than plasma?
Tight junction.
Yes, it's B. So the tight junctions are the blood cerebrospinal fluid barrier and blood-brain barrier restricts the passage of large plasma. Oh, also to mention, in the blood-brain barrier, it lets in, like for example, glucose, it will let in oxygen and carbon dioxide by diffusion easily because these are important molecules. But when it comes to glucose, we have transporters. Glucose and some other proteins, they have their own transporters. For glucose to the brain, it would be by the GLUT1. That's just for information. Can anyone read? Yeah. Huh?
Which physiologic mechanism primarily drives blood flow of CSF from subarachnoid space into the superior sagittal sinus via arachnoid B?
Yeah, exactly. Hydrostatic pressure gradient because CSF has higher pressure. All right, my colleague is gonna.
Okay, so I'll be explaining the coup and the counter coup and the scalp and dural. Okay, so for the coup and counter coup, for this case, if there is any brain injury, whatever it happens at the site of impact, there is going to be another site of impact at the opposite side. So let's say, for example, this was the site where basically the injury happened. So there is going to be a counter coup injury at the exact opposite site. And this is because of the inertia. This basically explains the whole mechanism out of it. That's it. Next one. Okay, so there's a question here. Can someone please read it?
A 55-year-old woman with aneurysmal subarachnoid hemorrhage develops progressive lethargy 2 weeks later. CT shows dilated ventricles. Which mechanism is most
What do you think?
Is it C?
Yes, fibrosis of the arachnoid villi will impair the CSF absorption. Extra question: what type of hydrocephalus is this?
Communicating.
Hmm?
Community.
Non-communicating. No. Yeah, sorry. Communicating hydrocephalus. Non-obstructive. Yeah. Alright, another question. I'm gonna read it. A 68-year-old man presents to the emergency department with a sudden onset of severe headache, dizziness, neck stiffness. Neck stiffness is a very important sign for meningitis, and difficulty with coordination. But don't let that trick you, okay? Neurological examination reveals ataxia and a wide-based gait. CT scan reveals blood accumulation in the subarachnoid cistern near the cerebellum. Which subarachnoid cistern is most likely affected? Subarachnoid cistern near the cerebellum. Which one?
C or D?
D.
Oh. Yeah, it is cisterna magna.
D.
A transverse MRI of the brain shows the anterior horns of the lateral ventricles. This is a high-yield question that is very important that we saw. Basically, you will get an MRI image of the ventricles, and then it showed us a few statements, and you need to know which one is true. Which one, without the MRI, which one is true based on our
B.
knowledge?
B.
Yeah, exactly. The thalamus surrounds the third ventricle. So if there is any sort of like a thalamic tumor, it would affect the third ventricle, block it, basically. Now my colleague Nada is going to continue. Thank you.
Okay, so I'll be explaining the scalp, the dural folds, and the sinuses. Okay, so I'd like you guys to answer these questions. So, how many layers are there in the scalp? From the knowledge you took this week, how many layers are there? 5. What are there?
Skin.
Connective tissue.
What?
Connective tissue.
Connective tissue.
Yes.
Aponeurosis. And then loose connective tissue.
Correct.
Pericranium.
Exactly. Which ones, if these 5 act as a single unit? The first 3, exactly. Which one is made up of dense fibrofatty layer?
The connective tissue.
The connective tissue, exactly. What is a very common pathology you see in the skin?
Spacious cyst.
Sebaceous cyst. Which layer is called the dangerous plane of the scalp?
The loose connective tissue.
Exactly, the loose areolar connective tissue. Which layer is the most vascular out of all of them?
Connective tissue.
The connective tissue. Where does the occipitofrontalis muscle insert to?
The third one.
The?
The third one.
The occipitofrontalis muscle, it inserts into one of the layers of the scalp.
The
One of the
upper
five.
aponeurosis.
The aponeurosis. It has 4 bellies, 2 here and 2 to the back. Okay, so this is very high yield. You need to know the difference between each type of hemorrhage in the scalp. When I tell you the word caput succedaneum, the first thing that needs to cross your mind is that it crosses the suture line. C is crosses, S is suture. So remember this when you want to do any question, it crosses the suture line. Difference between it and the cephalohematoma is this. Cephalohematoma does not cross the suture line, so it will take the shape of the underlying skull bone. Subglial hematomas, this is the characteristic feature. Raccoon eye, it's basically present in almost 90% of the cases, and I'm going to explain each and every one of them now. Okay, so caput succedaneum, it's basically the key feature. As I said, it crosses the suture line. The affected area is going to be the connective tissue, which is the second layer. Cephalohematomas takes the shape of the bone because the area that's affected here is going to be the pericranium, and the pericranium is firmly adherent to the margins. Yani, what are the margins here? The sutures. That's why any hematoma that occurs in the pericranium is going to basically take the shape of the bone, so it cannot cross the suture line. Subglial hemorrhage, it is affected, the area that's going to be affected is the dangerous plane of the scalp. So that's why it's called the dangerous plane of the scalp, because infections can spread easily as well as blood can spread easily. Hence the feature raccoon eyes. Okay, there's a question here. I'm going to read it and I want you guys to answer. A baby is delivered after a long and difficult birth. On examination, the baby has a fluid-filled cystic swelling on the side of the head. It is confirmed to be a hematoma and is noted not to cross the midline. What's most likely the location? What do you think?
Subperiosteum.
Subperiosteum. Yes. Question 2. A 65-year-old woman presents with a scalp laceration after a fall. Over the next 48 hours, she developed swelling of the scalp and the upper eyelids, creating a raccoon eye appearance. Which of the following explains why the blood spread in this manner?
The 3.
3. Why?
It's in the loose area.
Exactly. It's in the loose areolar connective tissue, so it needs to spread from this area. Okay. A man presents with significant scalp swelling and necrosis after a motor vehicle accident. Imaging reveals a hematoma spreading throughout the scalp, suggesting subgleal hemorrhage. So it already gave you the hemorrhage that's basically present there. Which of the following best describes the clinical complication that could arise if the hematoma spreads? What do you think is the answer?
Three.
3. Why?
The blood will transfer the infection.
Okay, so you're right, but here the characteristic feature, not the most important thing and the key word is subgleal hemorrhage. And as I said, subgleal hemorrhage is in the dangerous plane of the scalp. Why is it called the dangerous plane of the scalp? Because infections can spread and hemorrhage can spread. That's why the answer is 3. Because of infections. Infections will spread easily in subgleal hemorrhage. Okay, the vessels and the nerves of the scalp and the blood vessels and the veins. This is very important. You guys need to know the difference between where are they and what do they supply. I drew these and it helped me understand. I'm gonna upload the slides and you guys are gonna understand from each and every one of them where are the nerves located. So I'm gonna start with the arteries. Basically, the arterial supply is basically from the internal carotid artery and from the external carotid artery. The internal carotid artery gives out an ophthalmic artery, which basically supplies the anterior part of the scalp. The supratrochlear is closer to the midline, and then we have the supraorbital. Then the lateral part of the scalp is basically from the superficial temporal artery. Then the posterior part here is basically the posterior auricular and the occipital artery. So again, the internal carotid artery is only the first two, the supratrochlear and the supraorbital. The rest, the superficial temporal, the posterior auricular, and the occipital is from the external carotid artery. So there was a question that basically suggests what is the blood supply to the scalp, what are the main arteries? It's going to be the internal carotid and the external carotid artery. For the nerves, we have 5 anterior, 5 posterior. 4 of them are going to be sensory, 1 of them is going to be motor. When we start with the anterior, it's the same. Supratrochlear, supraorbital. It's the same. We have an extra nerve that's going to be the zygomatic, and you know the zygomatic, it's going to basically be over the cheekbone. Then we're going to basically have the auriculotemporal, and this is going to be the foresensory. I'm going to go over the motor next. Then we basically have the posterior part of the scalp. We have the greater auricular, which is going to be here. We have the lesser occipital, greater occipital, and the third occipital. Okay? These are all the sensory nervous supply of the scalp. When we go to the motor, we have 2. Madam, you guys studied week 3. What is the nerve that gives the motor supply to the scalp?
Trigeminal.
That's sensitive.
No, high sensory.
Facial.
Facial. On, there are 2 motor supply. It's going to be the anterior part and the posterior part. The anterior part is going to be the temporal, the posterior part is going to basically be the posterior auricular. طيب, why would we need a motor supply in the scalp? What's an important muscle? Yeah, what's this muscle? I mentioned the muscle. Exactly, the occipitofrontalis muscle. And the action of this muscle is to raise your eyebrows. That's why we need the facial nerve in the scalp. It provides the supply for the occipitofrontalis. The veins. This is very important. When the venous supply of the scalp is not that complicated, it's the same as the arterial supply, but it's the opposite. نفس الشيء, we're going to start with supratrochlear and supraorbital. Same thing. They're basically in the anterior part. Then they're going to join together and they're going to become the angular vein. And here. The angular vein. Then the angular vein is going to basically just continue down. It will drain downward. Then we're going to basically have in the anterior part of the auricle the superficial temporal and the maxillary. Superficial temporal needs to be here. The maxillary needs to be inside. They join together. So far we have 2 joining. Supratrochlear and supraorbital. And we have the superficial temporal and the maxillary. They joined and they joined. Superficial temporal and the maxillary will become the retromandibular. Okay? Or called posterior facial vein. Supratrochlear, supraorbital will join and to become the angular vein, or it's going to be called the anterior facial vein. Okay? So the retromandibular is here. Behind the auricle, we're going to basically have the posterior auricular. The retromandibular vein or the posterior facial vein will divide into anterior and posterior. Okay? The angular vein will join with the anterior part of the retromandibular, and the posterior auricular will join with the posterior part of the retromandibular. The anterior part will drain into the internal jugular, posterior part will drain into the external jugular. This is the venous supply. Did you guys understand? No, sorry. Do you want me to repeat?
No, I'm saying perfect.
Thank you. Okay, can we go to the next slide? This is very important and it's very high yield to know the venous supply to the cavernous sinus. Cavernous sinus is in the middle cranial fossa. تمام? When we start with the angular vein, what is the angular vein? I just explained it now. It's the joining of two veins, which are exactly supratrochlear, supraorbital will become the angular vein. They will go downward, and then it needs to drain to the cavernous sinus. It's gonna either choose the direct route or the indirect route. The direct route is going to be the superior ophthalmic vein, which drains into the cavernous sinus. The indirect route is going to be the deep facial vein, then the pterygoid plexus, then through the emissary veins, it's going to go to the cavernous sinus. Would you like me to repeat, or everything's good? Okay. This is very important. Okay. Okay. I just explained the venous supply. Can someone read and answer this question?
I want to read. The deep facial vein serves as an important venous connection in the face. It connects which of the following venous structures?
Which one do you think?
It's between B or A.
Between?
B and A.
You think? Okay, which one would you think most likely?
There were two routes.
Yes, two routes, direct and indirect.
Yeah.
Okay.
I would say
B?
B.
Okay, the answer here is D. Why? We had two routes, direct and indirect. Direct from the angular vein to the cavernous sinus via the superior ophthalmic vein. Yep, this is the direct route. If it chooses to go through the indirect route, it will go from the angular vein to the pterygoid plexus via the deep facial vein. So the deep facial vein connects the anterior facial vein and the pterygoid plexus.
Direct.
The direct is angular vein, superior ophthalmic, cavernous. Okay, so here the key feature is the pterygoid venous plexus, because the deep facial vein is what connects the angular vein to the pterygoid plexus. Okay. Okay. The external jugular vein is formed by the union of which veins? The external one that was here is by the union of what?
A?
Yes, posterior auricular and the posterior division of the retromandibular.
The anterior was for the internal.
Internal.
Exactly. Yes. Which of the following sensory nerves is required to be blocked before surgical removal of a sebaceous cyst in the scalp just behind the auricle? Lesser occipital. Why? Why not greater auricular? You're right, that's why.
The great only will reach the lobule of the ear.
Exactly, because the greater auricular is here. The lesser occipital is directly behind the auricle. But this is going to be the sensory supply. This is a picture which explains what I said. The greater auricular is going to be here. The lesser occipital is just behind the auricle. Okay, dural folds. Dural folds are basically, in this case, just made up of two layers, endosteal and the meningeal layer. The endosteal is the one that's firmly adherent to the pericranium, to the endocranium. The meningeal layer is basically the inner fibrous layer which forms the falx cerebri and the tentorium cerebri. Okay, the falx cerebri is what separates the two cerebral hemispheres. So it needs to be located in this shape. It needs to be a lunar shape. Anteriorly, it's very narrow. Posteriorly, it's basically blends with the tentorium cerebellum. So as you can see here, this is going to be the attached border, which is going to basically be here, and the free border is going to basically be this one here. Okay, so which sinuses are attached at each border? Which one do you think? I'm going to explain the sinuses afterwards, but what do you think is the sinus that's attached to the attached border and to the free border?
Superior sagittal.
Exactly. This is in which border? بالضبط. Superior sagittal is in which border?
Attached.
And the inferior sagittal?
Free border.
Exactly. Tentorium cerebelli is what basically separates the cerebrum from the cerebellum. تمام? So here we have the exact same thing, attached border and free border. Which sinuses run in the attached border?
Transverse.
Exactly. Which structure can be compressed by the free border?
Brainstem.
Which part? You're right, but which part? the midbrain. The free border is basically from this clinoid process to this clinoid process, this part here. So it's going to basically compress the midbrain. So there was a question that basically tells you there is a problem in the midbrain, and what is the dural fold responsible for compressing it? It needs to be the free border of the tentorium circular. Okay. These are extra dural folds. The diaphragm sella is basically between the clinoid process and basically forms the roof of the hypophyseal fossa, which is basically the pituitary, and then the emissary veins. Emissary veins is what basically connects interior to exterior. This is basically the main function of the emissary veins. So whatever it is inside, infections, hemorrhage, whatever it is going to basically spread exteriorly because of the emissary veins. Okay, so we have two sinuses, unpaired sinus and basically paired sinuses. Unpaired sinus is basically what I'm going to explain right now, but I want you guys to answer these questions. Where is the superior sagittal sinus located? You just said.
Attached border of focus cerebri.
Exactly. Where does it drain to?
Right transverse.
Exactly. What is a special feature of the superior sagittal sinus?
Arachnoid villi.
Yes, the arachnoid granulations, which my colleague explained, and she said that they're very important in the reabsorption. Where is the inferior sagittal sinus located? Exactly. Where does it drain to?
Left transverse.
Yes. Bas قبل left transverse.
Yeah.
Yeah, exactly.
Yeah,
straight
straight
sinus
sinus.
and then the left transverse. Where is the straight sinus located?
The
Attached.
superior
Tentorium
Yeah,
cerebelli.
tentorium.
Exactly. Tentorium cerebelli. And where does it drain to? Exactly.
left
اللي هو بالضبط.
So we'll join with the great
Great cerebral vein مع inferior sagittal
inferior
sinus
sagittal.
makes the straight sinus.
Okay. What are the other unpaired sinuses? You guys know. غير what we explained right now. It's superior sagittal, inferior sagittal, straight.
There's a basilar plexus, I think.
بالضبط. Basilar plexus is one of them. Occipital is also one of them. Okay. So intercavernous, basilar plexus, and the occipital sinus. And here the picture shows where each and every one is located. So the occipital sinus is going to basically be here. It needs to be in the internal occipital crest. Then the basilar plexus is along here, and the intercavernous sinus is basically around the cavernous sinus. Okay, the paired sinuses. We explained the unpaired sinuses, now we're going to go to the paired sinuses. Paired sinuses are the same, right and in the left. So, the superior petrosal sinus is basically located at the superior part of the petrous temporal bone. The inferior petrosal sinus is basically along the petro-occipital suture, which is right here, down. This is going to be the petrous. This is going to be the petrous temporal bone. So, this needs to be the superior, this needs to be the inferior. Then we have the transverse sinus, which basically, I explained, the right is going to basically be from the superior sagittal sinus, the left is going to be from the inferior sagittal sinus, which is going to be the straight sinus, and it joins throughout. Then the transverse sinus will form an S shape, which will be the sigmoid sinus, and then it will enter the internal jugular foramen and becomes the internal jugular. So I'm not going to explain the drainage هلا but this is the main idea out of it. The cavernous sinus, this is very high yield, and you need to know what are the content of the cavernous sinus, where does it drain to, and what drains to it. What?
Very high yield. Anything
Yes,
cavernous
this is
sinus
very
related
important.
is really important.
How I remembered it is with this mnemonic, O atomy. This is basically the content of the cavernous sinus. O is for the oculomotor nerve, A is basically for the abducens nerve, T is for the trochlear, O is for the ophthalmic, M is for the maxillary, I is for the internal carotid artery. These are the content of the cavernous sinus. So, if there was a question that basically tells you there was a thrombus in the cavernous sinus or there was a problem with the cavernous sinus whatsoever, any of these structures can be affected. Okay? So, the cavernous sinus receives blood from which structures or which veins? The ophthalmic vein, the sphenoparietal sinus, and the middle cerebral vein. It chooses to drain to. Okay. The cavernous sinus is going to basically, in this case, drain to the petrosal sinuses and the pterygoid plexus. Okay, next. Okay, the sequence of drainage. Now we started in the beginning. I told you the superior sagittal sinus will basically drain into the right transverse. Inferior sagittal sinus will become the
straight.
and then left transverse. From the left transverse and the right transverse, so as I said here, inferior sagittal will basically go to the straight and basically become the left transverse. The superior sagittal will go to the confluence and then it will become the right transverse sinus. Once they become the right transverse sinus and the left transverse sinus, they will receive the veins from the superior petrosal. So this is going to be the first range, superior petrosal veins. Then, when the transverse joins and becomes the sigmoidal veins, they will receive the drainage from the inferior petrosal veins. Okay? And then the sigmoidal sinuses will basically become the internal jugular once they enter the jugular foramen. Do you want me to repeat or is it
Yes.
good? Repeat that again?
Just once more.
You want me to pick it up؟
بس من superior petrosal sinus.
Okay. الانفير أنا أول شيء the inferior sagittal sinus will basically become a straight sinus. من straight sinus it will basically become a left transverse. صح؟ straight sinus حيصير ال right transverse. أول ما it becomes transverse, the right and the left, it will receive the first drainage from the petrosal, the superior part of the petrosal. So the superior petrosal sinuses.
So after the transverse, then the superior.
بالضبط. Then once it becomes the sigmoidal sinus, it will receive the drainage from the inferior petrosal. Okay? From the inferior petrosal, it will basically in this case go to the internal jugular through the forearm.
Good.
Okay? Okay, question 1. A patient presents with severe headache and visual disturbance. An MRI shows a clot in the venous sinuses located at the intracranial occipital protuberance. This area is known as the confidence of sinuses. Which of the following is not part of the confidence of the sinus? You sure? Which one? You said occipital.
I think it's occipital.
You think it's occipital? Which one do you think it is? Let's say it's occipital. Okay. The answer here is going to be just here, sagittal. The confidence of sinuses is basically superior, occipital, transverse, straight. There is a confidence of sinus that's going to basically be located between the fulx cerebri and the tentorium cerebelli. Okay? It's basically formed by the superior sagittal, occipital sinus, transverse sinus, and straight sinus. Why is it straight, not inferior? And inferior drains into the straight. فخلص inferior right now is not part of the confidence of sinuses. It's gone because it becomes the straight sinus. Okay, so it's formed by this is very important. Okay. A fracture in the base of the skull involving the petrous temporal bone might directly affect and damage the following structures, except. Which one do you think? Internal auditory meningitis? Okay. The answer here is straight sinus. I'm going to explain for you. Okay. Here's the petrous temporal bone. When the straight sinus? Where is it?
It's under
Where's the petrous temporal bone? Will it be affected لو كان في thrombus in the petrous temporal bone? No, that's fine. Okay. This is the only one that's extremely far from the petrous temporal bone. This is very important. Thank you guys.
Thank you so much.
Thank
Any
you.
questions?
Any questions would you like to ask?